All right, well, thank you. We'll go ahead and get started. And just a friendly reminder, if everybody could just please mute your sound. And as we go through our presentation today, if you think of any questions that you might have, if you would please include those in the chat, and we will have some time, hopefully at the end of our webinar today, to do some questions and answers. But thank you all so much for attending today. My name is Nan Carter. I am Manager of High Reliability and Innovation for the South Carolina Hospital Association. Welcome today. We are so glad that you all can join us for our first webinar of our Zero Harm webinar series of 2023. Last year, as many of you know that participated, was a pilot year for us in doing our webinar series, and we received great feedback from all of our member hospitals, and they found the webinars to be extremely valuable. And so we are excited to continue to provide those webinars for you all today and for this year. So today we are going to be focusing on surgical site infection prevention, and specifically talking a little bit about our South Carolina Surgical Quality Collaborative. And so welcome. And just to give you all a little bit of information on our Zero Harm program, as this all is related. Just to recap a little bit of 2022, we had a banner year with over 60 hospitals winning either one or more Zero Harm award. A total of 295 clinical awards were given out to those member hospitals, which was a record year for us. As of last year, since the beginning of the Zero Harm program, we actually distributed out over 1,500 awards. So kudos to all of you for your achievements in high reliability and Zero Harm in your facilities. Just to break that down a little bit for you, that equates last year's 295 clinical awards equates to 117,530 central line days without harm. That also equates to 204,475 number of patient days without harm. Number of surgical procedures without harm, specifically surgical site infections, was 5,839 procedures. And the number of few days in hospitals for patients was 1,700 fewer days in the hospital for patients. So all of that equates to, just last year, those awards, a cost savings of $6 million for our facilities. Going down a little bit deeper dive into that data, we had 37 independent member hospitals who had no infections or harm in their surgical site procedures. And Zero Harm program focuses on 4 specific surgical site infection areas, some of those being the most challenging and highest infection rates. So many years ago with the Zero Harm program, the areas that we chose to focus on and reward hospitals for Zero Harm were abdominal hysterectomy, colon surgery, knee replacement, and hip replacement. And as you can see here, this is the number of awards that were given out last year, equating to a cost savings of $1.17 million. And this is a list of all of our hospitals. Many of those are members of the South Carolina Surgical Quality Collaborative. So kudos to all these hospitals for winning one or more surgical site infection award last year. So at this time, I will turn it over to Diana Zona, who is Executive Director of our foundation and works very closely with the South Carolina Surgical Quality Collaborative, and we'll be introducing our speaker today, Dr. Mark Lockett. Just if you'd like to access any information about Zero Harm, please visit zeroharmsc.org. You can see a full list of all of our award winners and look a little bit more specifically at those surgical site infection awards.
Thanks, Nan. Hi, I'm Diana Zona, and the South Carolina Hospital Association has had the pleasure of working closely with Dr. Lockett, as well as other folks who contribute to the Surgical Quality Collaborative, other organizations, since its inception. So we're really excited to have him speak today. The Surgical Quality Collaborative, actually, Dr. Lockett is the surgeon lead for it and has multiple leadership roles working at the VA and MUSC. And the collaborative has been a wonderful experience as far as successes, lessons learned. They have a fantastic networking opportunity. The group meets quarterly and actually all comes together. So surgeons, nurses, quality folks, all in the room, learning from one another, sharing openly with one another. So that has been just a great opportunity to see the collaborative unfold and succeed and just move forward. So we really appreciate Dr. Lockett being part of the Zero Harm webinar today. Personally, I've heard his presentation probably 30, 40, 50 times maybe. And I must say that each time he does tweak it and make it a little bit different. And I learned something every time. And he's a fantastic speaker. He didn't pay me to say that. He truly is, and a great leader for this collaborative. So thanks again, Dr. Lockett. We appreciate you being part of the Zero Harm webinar today, and it's all yours.
All right. Thanks, Diane. I really appreciate it. Can y'all hear me okay? Okay, good. Let me try and share a screen. So thanks for the introduction. And what I'm going to talk about, and I know we probably have a lot of quality management type folks on, maybe some infection control folks, and I'm going to talk about surgical site infections a little bit beyond what you might think, which is the typical like skip measures and ORX measures and things that a lot of quality people know. I'm trying to share my screen, but I'm getting the disabled button. So can you let me share? Is that possible? Or do you want to? Here we go. All right. How about that? Can y'all see me? All right. Perfect. All right. So get it scrolling here. So we'll talk a little bit about the pathophysiology and identification of surgical site infections, some of the risk factors that are involved. And then I'm going to take it in a little bit of a different route, but I hope that you'll appreciate what I'm trying to go over, which is a little beyond what's typically looked at from a hospital standpoint for managing surgical site infections. So I'm going to talk about something that surgeons can do. And I'm going to talk a little bit about the patient approach, basically training for surgery, rehabilitation. And by the way, all these things are things that we talk about and that we've done some educational programs on within the Quality Collaborative. And then I'll go over the more common things that folks talk about when they're talking about preventing surgical site infections. So some of the OR things that we do, the perioperative things that we do. I'm not going to dig too deep into those, but we'll run over some of those. Some of those are individual talks by themselves. And I want to show you an example of ways that we can engage our patients more in managing their wounds and knowing what to look for and how to care for their wounds, because I don't think we do a very good job of that. And by full disclosure, I am a surgeon. I'm a general surgeon, and all the failures that I might talk about are mine on this talk because I've failed in a lot of areas in educating my patients on ways to take care of their wounds. We'll talk a little bit about treatment and then expand a little bit more on the Quality Collaborative if we have time, and then we'll field some questions. These slides will be sent to the group. That's what Nan's told me. And because I figured that would actually be the case, I have included more slides than I will be able to go through, and some of them are messy. So just as a warning, there are going to be some slides where I'll say, I'm going to skip that. It's really more for your use afterwards than for me using it as a talk, because y'all don't want to listen to me talk any longer than this hour that we're on, and these slides could be a good bit longer than that. So let's dive in. So how do we define it? Well, it's an infection related to an operative procedure that occurs at or near a surgical incision within 30 days or 90 days for prosthetic. So that's the general definition of a surgical site infection, and it's usually manifested by redness, pain, drainage, or fever. And I'll talk a little bit about those because those exist, maybe not fever, but even that to a degree can on most incisions. So incisions do hurt. And you can get redness even if something is not infected, and drainage doesn't inherently mean there's an infection. And so sometimes actually deciding whether or not a wound is infected or not can be a true challenge, as I'm sure most of the people on the call know. It accounts for nearly 40% of nosocomial infections in surgical patients, which is the number one type of, by single category, nosocomial infection in a surgical patient. There's lots of varying data about the incidence of this nationally. It's estimated that there are about 30 million operations done each year, and about 2 to 5% of those have a surgical site infection, and I'll show you some specific categories in just a minute. So it's the second most common adverse event for hospitals behind medication errors. So this is just a picture of an abdominal wound that shows some redness and some irritation that would be a typical thing that you might see with a surgical site infection. Again, over probably between 300,000 and maybe as many as 1 million surgical site infections a year. Much higher risk of death if you have a surgical site infection, more days in the hospital, varying estimates on the dollar amounts, but probably a chunk of money, as you just saw, and kudos to the group for zero harm in the infection realm, because these are really hard to truly get zero infections for many of the operations that Nan showed you earlier is really very impressive. So, hand clap emoji in the chat for everybody, because that's great work. Huge costs that are associated with this, and of course, the worst is just patient inconvenience. It's really a significant morbidity for a lot of wound infections. We have to do procedures, antibiotics, time off work, readmissions to the hospital. It's a huge part about readmissions, and I'll show you a little bit of data on that as well. In general, the way that we look at preventing surgical site infections is how they're constructed, and this isn't perfect, but we think about the dose, meaning the amount of a particular bacteria, how virulent that bacteria is, and then divide that by the resistance of the patient. So cut the number of bacteria, hopefully not have patients exposed to worse bacteria, and then make sure the patients are strong, use appropriate antibiotics as well. That would be part of the resistance of the patient to try and limit that risk of a surgical site infection. In general, we think it takes about 1 million organisms per gram of tissue to significantly increase the risk, but that drops markedly if a prosthetic material is present. So, total joint replacement, mesh in the type of surgery that I do, things like that can really drive up your risk. You don't need as much bacteria in that situation to get a surgical site infection. In general, the bacteria comes either from the patient, which is the most common source, or from the environment, hospital or the surgeon or anyone really taking care of the patient. But most of the times the infections are derived from bacteria that are native to the patient. So pretty messy slide here, but if you look on the left-hand column, you'll see multiple different types of surgeries, and this is a broad analysis, and then 3 columns over there, the SSI rate, and you can see that it varies pretty broadly across multiple different types of surgeries and specialties. In general, if you pool all this together, the risk of a surgical site infection is close to 10%, and nearly 60% of those are discovered after discharge. And that's an important part of this conversation is if you're just reviewing and looking at charts that are inpatient charts, you're not going to capture the majority of surgical site infections. And so again, kudos, 10% risk is pretty high for about anything. And for those of you who are able to get zero infections, that's great work. So surgical site infections are also linked to other complications that our hospitals frequently get dinged on. So this is an example from a JAMA article in 2015, which is the unplanned readmission rate for about 500,000 operations was about 6%. And it ranged across different types of surgeries. You can imagine certain surgeries have a higher risk of readmission than others. The most common reason, though, for a readmission was surgical site infection. That was about 20% of the patients. That's why they got readmitted to the hospital. So that's why I'm expanding this conversation beyond just red wounds and drainage and things like that to what's related to the surgical site infections, readmissions, potentially even mortality associated with it. So what are the risk factors? So emergency surgery, cancer therapy, immunosuppression, steroids is what we typically think of with immunosuppression. And when you see in this talk OR, that stands for odds ratio, meaning that if you're on steroids, you're almost 2.5 times more likely to get an infection than someone who's not on steroids. But we have a whole lot of new medications for various things, whether it's cancer or autoimmune diseases, where we have immune therapies that really can impact surgical site infections and put you at higher risk for any type of infection, but certainly an SSI. And so it's not just steroids anymore. And it's really hard for surgeons even to keep track of all of the medications that can potentially be immunosuppressive, things that treat, Crohn's disease and various autoimmune disorders are on this list. A remote infection. So this is one that is sometimes under appreciated, which is that if you have someone who's got, let's say, an infected ingrown toenail, and you're going to do a hernia repair on that patient, the risk of having an infection related to that hernia repair, typically use mesh in a hernia repair, so your inoculum is lower, is significantly higher if you've got an infection elsewhere. So that's part of the reason that making sure surgeons do their sort of 24-hour H&P update and do it from a real world standpoint, not just saying, yeah, I got to do it because it's like a Joint Commission checkbox, but is to make sure that there's not a remote infection, especially if you're doing an operation that involves an implant. That could be a huge increased risk for infection. Malnutrition is a major risk. Anybody with a BMI basically less than 20 has a significantly higher risk of having an SSI and multiple other complications as well. Smoking is on the list. I'll include, we don't have good data on it yet, but I'm going to include vaping in the smoking category. Anything that basically is a tobacco product. We sometimes get in big arguments with our patients as to whether or not we say smoking and they say, oh, I don't smoke, I vape, or I, whatever. They have different ways that they get nicotine and smoking like substances in their system. But certainly increasing a rate, and this data shows between 4% with a non-smoker up to as high as 23% in smokers. Our plastic surgeons frequently will not do any kind of reconstructive type surgery or any plastic surgery, elective surgery, if someone's smoking. That's typically true with orthopedics as well for things like total joints. Obviously, surgery location matters. If you're working in contaminated fields like colon surgery, you're going to have a higher risk of surgical site infection than fields with minimal bacterial exposure. In general, the more minimally invasive surgery you do, so the smaller the incisions, the less risk of an surgical site infection. Just the wounds are smaller. There's also data to suggest that OR time matters. So if you're over 2 hours, the odds ratio goes up. You have to be a little bit careful about that kind of data because it's so confounded, which is why is an operation taking longer? Is probably because it's a more complicated operation. And it's very hard, even when you try and dissect out and control for those things, to make time a completely independent variable. But obviously, as a surgeon, we do try and operate as quickly as we can for multiple reasons, but this is one. The less time that you're in the OR, the less time somebody's in a hospital, the lower the risk of infection. So obesity, so high body mass index, can cause or contribute to surgical site infections, congestive heart failure, and diabetes. And what I'm showing on this graph on the right is our own quality collaborative data that just gives you an idea of the difference in complications between a diabetic and a non-diabetic. And as you can see, the overall morbidity there in the top column for diabetics, insulin-dependent diabetics, is more than double what it is for a non-diabetic. So people with diabetes have a high risk for multiple different complications. SSI in this case is about a percentage point higher for insulin dependent, and non-insulin dependent but still diabetic also have higher risk. So this is just showing you the kind of data that we can get from the quality collaborative. And then as we roll out these projects, which I'm going to talk about next, we can see how they impact this data. So it's a very valuable tool to help us know what the best thing, to help us learn the best things to use to manage our patients. And then functional status, so frailty. And I do want to talk about frailty a bit because this is a little bit outside of what we typically think about from a surgical site infection standpoint, but I think it's something we need to be spending a lot more attention looking at. And so most of what I'm going to talk about really slides into the mortality category, but will impact SSIs as well. And so let me talk about that. And this is the surgeon's perspective of when I see a patient and what I can potentially do to lower the overall morbidity and mortality rate. So one of the things that I didn't realize as a surgeon, but the data now pretty clearly show, is that there's no such thing as a low risk surgery in a frail patient. So if you look at the numbers below, even if I'm doing a low risk surgery in a patient who's frail, their risk of dying within 30 days after that surgery is as much as 10%. If you'd asked me that a few months ago and before we sort of did some education on this within the collaborative, I would have guessed that if you do big operations on frail patients or very frail patients, that your risk of mortality is a good bit higher. But if you did small operations, cataract, hernia, things that aren't really considered a high risk, that there really wouldn't be that much difference. That's actually not the case. So patients who really are, struggling with daily activities have very high risk for surgical intervention. And so from that standpoint, we need to maybe think about those patients a little bit more and get them prepared for surgery a little bit better. So how do we do that, or how do we identify these patients? Surgeons in general have this thought process of who's sick and who's not. This is actually a pretty easy system called the Risk Analysis Index that we've shared with our sites. The C stands for clinical. And it's a 14-item survey, which a lot of clinics can do either by an RN, it can be done by the surgeon or an APP, but it actually can be done as the patient's checking in. If you have a good electronic system, they can even do this themselves. And it creates a score that would just tell you how high risk someone is. And if you start getting scores on that graph over there on the right, if you start getting scores that are greater than 36 or 37, you really need to think a little bit. So that's why the term surgical pause comes into play. It's been highly validated at multiple centers. This is obviously, it's been around for a bit. This paper was from 2016 and is very good at predicting. And again, we're talking about mortality here, not specifically SSI, but all the morbidity risk increases when you're dealing with frail patients. This is just a quick list of what that scale has. It's things that you might think of: age, sex, activities of daily living, history of cancer, renal failure, congestive heart failure, shortness of breath, things that surgeons kind of, look at but don't usually quantitate. This is a way of quantitating how high a risk someone is. And this just gives you an example of the different curves for patients who are at the highest risk versus the lowest risk. As you can see, once we start, there's like an inflection point when you start getting really high risk. The drop off as far as the much higher risk of mortality is really significant in the worst group. So the worst 20% of patients make up like 80% of the bad outcomes. And so we need to be able to identify those patients on the front end and then figure out what we're going to do to improve them before we ever get them to the operating room, or if we even get them to the operating room. And so that's what this shows. So this is the surgical pause idea. So a patient presents to clinic, I take a look at him, I go, ooh, that person looks a little frail, run the risk assessment, determine whether or not that patient is high risk. If they are, then I've got to decide, does this hernia really need to be fixed? If they have cataracts, maybe they need to have cataract surgery, but if they're really frail, what can we do to tune them up a little bit before surgery? So that's where prehabilitation comes into play. And this is an example of how that would work. So if I identified the patient as being frail, have a group that would get together. Maybe this is anesthesia, the primary care doctor, the surgeon, and sort of talk about this high risk issue and see what we can do to improve the risk factors. One hospital, and I'll show you some graphs of this, was able to decrease their mortality from 25% to 8%. So a big advantage to having those conversations and deciding how we could maximize patients, get them tuned up for surgery. Also, some patients decided when they knew the risk was as high as it was that they did not want to have surgery. And sometimes there's non-surgical ways that we can manage certain problems. And so about 20%, a little over 20% of people changed their minds and didn't ultimately have surgery in this particular data set. And then prehab, I'm going to talk about it in a little bit more detail in just a minute. So basically trying to get people stronger for surgery and therefore lowering the risk of complications, including surgical site infection. So this is just, again, what happened at one facility. This is actually a VA out in Omaha where they were having issues with mortality. They put in this frailty score. As you can see on that graph, the mortality dropped significantly because they were getting patients tuned up for surgery, or they were just deciding to use non-surgical options. So it dropped from 24% again down to 8%. So what about the patients themselves? So if a surgeon, pauses a little bit and says, okay, we need to tune the patient up a little bit before we go, or maybe a lot, before we actually get to the operating room, how can we do that? And does it work? So this is an example of a program that was started in Michigan. We work closely with the Michigan Surgical Quality Collaborative, and they've got some great projects that they're kind enough to share with us. This is one of their projects where they were giving patients basically a pedometer. Now, a lot of people have smartwatches now that will do this on their own, so you don't even have to give people pedometers. But when they did the study, they were doing that. They were giving them symptom spirometer, nutritional and stress management counseling, and they would work on smoking cessation, and gave the simpler patients just a DVD and a brochure, and then they would send automated text messages and check-ins to say, hey, how's it going? And then the more complicated ones, they did a formal multimodal prehab program, a 6-minute walk test, a sit to stand, chair test, and got them involved with pulmonary rehab for the bigger operations. And they were able to show a 30% reduction in severe complications, including surgical site infections. It reduced the average total hospital charge by nearly $22,000 per patient. So pretty good return on investment for what seems like a pretty simple process. So here's another just example of this is looking in Medicare beneficiaries. They were able to cut the length of stay significantly by a day, which as full as our hospitals are, if we can cut the length of stay, that would be great. And more patients went home after this project. So the mean amount of payment for Medicare beneficiaries went down by 10%, which is pretty significant. So Medicare is interested in these type of programs. So, but there's effort that's involved. So is it worth, is the effort, the people you have to put in, if you get them pedometers or if you're doing the incentive spirometers, is it worth it? And so this looked at colon cases and an optimization visit. And I do want to say that most hospitals will send patients from the surgeon's office to like an anesthesia or some sort of a pre-op clinic, which does some degree of screening, but most of what is done in the surgeon's office in most places that I'm aware of and in anesthesia pre-op clinics does not rise to the level of what we're talking about here. So this is a more involved preparation process. I do know that some orthopedic offices will have an optimization type clinic. That's the most common specialty that I've seen this in, that really tries to improve patients' health and medical conditions before surgery. In this particular example, the cost of everything they rolled into this was about $700, but saving a complication was almost 15,000. And so the summary of that was it's a very cost-effective thing to do, even though you had to commit resources and time to doing it. Another thing that we think is important is the surgical moment when people are having surgery. That knowledge that you have to undergo surgery is a very teachable moment for patients. We can really impact their lifelong knowledge and motivation to improve many things in their life. We're working on that, especially with diabetic patients. But this is a good example of why surgery can be so important for something like smoking. So this is an example of a thoracic surgery clinic where, and I showed you before that smokers have a much higher risk of surgical site infections. And so getting people to stop smoking is very difficult to do. And typically the success rate of stopping smoking is less than 10%. But in this particular situation, with surgery as kind of the motivator, nearly 75% of patients were willing to try and stop smoking. And of those, nearly 75% were able to quit by the time of surgery. And many of those were able to continue not smoking after their surgery. So surgery is really a time when people are much more motivated than just, run-of-the-mill normal day-to-day life. Around the time of surgery, they're much more motivated to do things that will improve their health. And many of them will maintain those good habits past surgery. So we need to use that opportunity to try and improve our patients' overall health beyond the benefits to me specifically as a surgeon, trying to prevent complications, and from a hospital standpoint, trying to prevent complications. This is an example of why we're focusing on diabetics. This is another one where the diabetes was managed more aggressively and showed a decrease of nearly 12% in the complication rate, which included surgical site infections, and cut the hospital length of stay by about a day and a half. And those are all things that we're interested in as far as better outcomes for our patients and less time in the hospital. So now the hospital approach. So this is the stuff that most people, infection control, quality management offices, OR nurse managers and things know. And I'm going to go over these pretty quickly, but I think they are important to discuss. So first of all, we need to make sure that we're classifying the wounds correctly. Most of you know this, but I've included it for, just so you have a good reference. And this is a general snapshot of what the overall predicted infection rate is by that type, that wound class, so that you can have that, sort of to compare your own rates to. And again, in the Quality Collaborative, you have great data to be able to do those comparisons. So you've got infection control processes, operating room cleanliness. You want to limit traffic in and out of rooms, laminar airflow, positive pressure rooms, things like that. The evidence for a lot of the things that we do from a hospital standpoint really revolves around not direct changes in surgical site infection data, but more indirect methods. So basically trying to limit the amount of bacteria, and with the idea that changes the formula that we talked about at the beginning. And if you get a lower bacterial load, that your risk of SSI is lower. So most experimentation and studies that look at these processes we're talking about here really are looking at culture dishes and things like that. So if I use this particular type of disinfectant, does the culture show less, not on a patient, but on a Petri dish? Then I use that particular type of disinfectant. And that's where most of this data comes from. Making sure your sterile processing systems work well. Obviously, that's very important. Surgical attire, so maintaining the sterile field. So I had to throw in scrub hats because there was a humongous brouhaha about 3 or 4, I don't know, actually more than that, I guess, years ago, where Joint Commission wouldn't allow scrub hats. There really wasn't great science to say that you couldn't wear your own scrub hats. So, there are people probably on who have Clemson scrub hats and Carolina scrub hats and things along those lines. Actually, a few hospitals then did some studies on this, and there was no difference in surgical site infection rate between wearing your own scrub hat and wearing a disposable scrub hat. If any of you still have folks that want to shave, and please, mainly now what we see is patients who may shave before a surgery. We don't want them to do that. It creates little micro cuts in the skin and actually increases the risk of a surgical site infection. So you can see there in the parentheses, people shave before surgery, the risk is nearly 6%, whereas clipping is down less than 3%, and depilatories are even less than 1%. You want to do hair removal as close to incision time as you can and not make a mess. We want to make sure that the antibiotics we give are appropriate, that they're on board basically when we make our skin incisions, and we want to make sure that we're not forgetting to redose for those longer operations. Unfortunately, the skip measures, which were started in 2002 and largely revolved around antibiotics and antibiotic timing, really in the global data have not shown a huge impact on surgical site infections. So we've really got to look beyond some of these efforts, which is why I talked about the frailty and the prehab, because a lot of the efforts that make intuitive sense to help aren't quite getting the job done. What about decolonization? So this has been a big topic, especially in certain specialties, orthopedics and cardiac surgery being the most common, I think, that talk about this. And how do you do it? So mostly you're talking about chlorhexidine, some version of bathing, an oral rinse, nasal stuff to cut out colonization. The data is pretty mixed. A lot of hospitals have done screening programs, especially for MRSA in the nose, and those are fraught with challenges. So other hospitals have kind of dropped that and gone to just basically universal assume that everyone has MRSA colonization. And in the cardiac and the ortho literature in general, I know most of the folks that I know in this category where I am down in Charleston are doing universal decolonization for MRSA before total joint surgery and cardiac surgery because of the risks of infection when you've got a sternal infection or a prosthetic infection. As you can see there, probably worth it in that group. The risk without doing the decolonization is about a little less than 4%, and it's about 1% with decolonization. Other surgeries has been less fruitful with, I'll say. Bowel preparation for colon surgery is a must, but it's not useful for other types of abdominal surgery. Alcohol and chlorhexidine is better than your iodine stuff. I think most people know that. We want to keep people warm, and that actually is a big issue, and we don't think about that enough. But if you're able to keep people normothermic, your risk of having a wound infection goes down considerably. Glove changing has mixed results. Surgical technique and time, we talked about the 2 hours in laparoscopic or minimally invasive surgery versus open. Abdominal wound protectors in general work. They are probably worth it, especially if you're doing bowel surgery where you've got contamination. Supplemental oxygen actually has some data that supports its use. So keeping people, even if their SATs are okay, keeping on people on oxygen post-operatively, but the data is pretty weak. And so that's not routinely used, but it is something that could be considered in a high-risk patient. Keeping blood sugars normal, but not too low. And that's been one of the problems is sometimes very stringent blood sugar programs can get people hypoglycemic, which can cause its own set of problems, but trying to keep blood sugars as close to a normal range, 100, 150 is probably a good range, will lower your risk of surgical site infections. And try and avoid transfusions because they will increase they basically have an immunosuppressant effect and can increase your risk of infection. Antibiotic irrigation might help, but the data is very mixed. There's some data, typically from the suture companies, suggesting antimicrobial sutures may help, but the evidence is not great. Negative pressure wound dressings has been a significant, gotten significant momentum with a lot of surgeons. I know a number of orthopedic and plastic surgeons who use negative pressure wound dressing. This is like the Prevena system, for those of you who know that. And it may help. The difference is not huge, and there are some studies suggesting it's not cost effective. I think in certain circumstances with prosthetics, let's say total joint surgery being another example, it may make sense, or breast reconstruction where you've got implants, it may make sense to use these negative pressure dressings. There's going to be more data coming out on this in the future, but right now, it's a bit plus minus. Topical antiseptics really don't help, and so sometimes patients will go home and put bacitracin and things like that on wounds, and that is not helpful. So post-discharge, I'm just going to show you quickly an example of information that we've provided to our quality collaborative hospitals, basically a handbook for post-operative, or not, it's a handbook really for all of surgery, but can be modified by surgeon practice specifically to the types of surgery they do. But this is an example of what that information, that's why the document title's gone, is so that surgeons and our sites can edit it the way they want to and give their own instructions. But you want to tell patients how to handle their wounds. I've had patients come back to my office who still have a dressing on, and I was pretty certain I told them to take the dressing off. And clearly I didn't give good enough instructions. And so we've really got to tell them what to look out for, when to call us if things look red or have drainage, how to wash their hands beforehand, not to put bacitracin or whatever on the wound, those kind of things. So next is a category on identification and treatment. And I'm going to go through this very quickly, but I did include it so that you could have it as a resource at the, once this is sent out. So first of all, as we mentioned at the beginning, it can be really hard to figure out whether or not a wound is truly infected. Redness, drainage, certainly when you start getting fever in the mix, you start being a little bit more suspicious. Pain is present at all incisions, but typically pain out of proportion to a normal incision. Really, how to determine whether something's infected is really how is the provider managing that? Did the wound get opened? Did what was described when it came out? Are they starting antibiotics? Those are the kind of things. It's really how you manage what you're seeing as to whether or not it's defined as an infection. From a real world standpoint. So, and most again occur post discharge. So if you really want to know your wound infection rate, you've got to look at outpatient notes. How to manage it? First of all, source control, most important. Drain the pus, stop any ongoing contamination. If you got a bowel anastomosis that's leaking, you got to fix that. If possible, remove foreign or necrotic material. That obviously becomes a big issue when you're talking about things like joint replacements and hernia repairs with mesh, because trying to figure out whether or not one of those is infected, it's a big deal to go remove hardware. You got to make sure that it's truly infected before you do that. Improve patient nutrition and strength. We don't always think about that. We jump to antibiotics, but we really want our patients to be exercising. That doesn't mean like going to the gym, but walking around and getting good nutrition. So potentially even nutritional supplements in this setting. And then antibiotics. So I wanted to throw in, because I figured we had a lot of quality management type folks on here. There is a new standard for antibiotic stewardship, and I'm showing what those requirements are that started as of January of this year. And basically making sure that you're using antibiotics only when you should, and that you've got some quality improvement efforts in that field. And so I'm going to show you a few things just quickly that may fit into that category as it relates to surgical site infections, which is really cutting the amount of antibiotics we give, narrowing the spectrum and cutting the amount. So you typically only need about 4 days of antibiotics for intra-abdominal infections. And this is just an algorithm that shows the different antibiotics that you may want to use. I'm going to go through this again very quickly, just giving it to you for reference. And typically for things that are quickly controlled, source control, you only need 24 hours of antibiotics for things like a bowel perforation that's operated on quickly. Again, 4 days if you've got adequate source control, a little bit longer, 5 to 7 days if you're not sure if you have adequate source control. So that's like diverticulitis where you haven't operated. And there's really insufficient data to evaluate the immunocompromised to know how long to do antibiotics. Threw in a little appendicitis because it's common, and basically the data says anywhere from 1 to 3 days of antibiotics, even in complicated appendicitis, is sufficient. And a lot of people will send folks home with 7 to 10 days or even 14 days of antibiotics, which really isn't supported by the literature. Skin and soft tissue, really, you got to decide how purulent it is and whether or not MRSA could be involved, because you want to use a MRSA coverage. And typically anywhere from a couple of days to 5 days of antibiotics is all you need for skin and soft tissue infections. And there's a flow chart for you. Gram-negative coverage is not typically needed unless you have, bowel surgery, some urologic procedures, or burn wounds. And so it's really important to be good stewards of antibiotics and how much antibiotics we prescribe. We tend to heavily overprescribe right now. And most of this data, as you can see, suggests we should be prescribing a lot less than surgeons typically prescribe. So that's my surgical site infection talk again, and I hope that was useful. As you can see, I went over things that are beyond just infection, but are linked to it, like readmissions and mortality and frailty and people training for surgery. And so we have shared this type of information through the Quality Collaborative, and I just wanted to give a little bit of information in the last, 3 to 4 minutes here to show you what the Quality Collaborative does. We started in 2015. We want as many hospitals in the state involved as we can because we all learn from each other. Was originally funded by Blue Cross Blue Shield Foundation, the Duke Endowment. We're now working through a rewarding excellence program and the state's Medicaid value-based payment system, and I'll show you that in just a second. We're just trying to get better. That's basically it. We're trying to improve quality. We learn together. We make mistakes, and some hospitals will make a mistake and tell other hospitals, and the other hospitals don't have to make that same mistake. It's just a very sort of simple, engaged process where we talk about what we're trying to do to improve quality. And we have a very good data system to track whether or not what we're doing is working, which is we have abstracted data that's risk adjusted, that's available in real time through a web interface that lets you know what your SSI rate is and each surgeon's SSI rate. And then they can compare that to other surgeons, not by name, but and see how they're doing relative to their peers in other hospitals. We share best practices. Again, we have this web-based interface. It's reliable data, and so surgeons in general will believe it. Coding data can be a little bit of a challenge because it's just got so many areas where it can be misleading. And so having quality, abstracted, look at the chart, very clear definitions, not just based off of words, but based off of reality, gives you risk-adjusted outcomes that we then use to try and improve quality. It's for general surgery. That's what we work on, but the stuff that we work on can apply to other specialties. But right now, we're just focusing on general surgery. We're trying to improve quality, improve value. We want to give the highest quality of care at the lowest possible cost. And I'll show you some data on this, decrease disparities, because it's actually our Black and older population that has the worst outcomes in the state. And so we're trying to narrow that gap. And then the program, I'll show you how we have sustainability. So this just shows what we've been able to do since 2015, and the overall morbidity has gone from about 9% down to about 7%. I'll show you that's been a much bigger change for people who do not have commercial insurance. So our Medicare, Medicaid, self-pay population has much worse outcomes than our commercial insurance payers. All categories that we're working on have improved. This just shows the blue bar is the overall morbidity for our hospitals. The red bar shows predicted morbidity through our system. So we put that in there just to show that hospitals aren't, this is a sampling methodology, so that hospitals aren't sampling cases that are just simpler and easier to sample. So the overall risk of cases has gone up over time, but the outcomes have improved. This is corrected for the types of surgery and just shows anything to the left of the bar shows improvement, and things where everything is to the left of the bar, the two small bars show the statistically significant improvement. So everything's gotten better across our hospitals. And this shows the non-commercial group, and you can see that the overall risk is much higher. It started nearly at 12%, 11.5%, and down to about 8.5% for overall morbidity in the non-commercial group. And that just shows the same graph for the non-commercial outcome. And this is the data I wanted to show on disparities, which is that the black bar are older Black patients. The blue is the non-Black that are older, and then the non-Black younger patients are below that, and the green younger Black patients are the green one. And you can see we're trying to get those bars to come together. They're all improving and trying to get them closer to each other. This is some data that we looked at to determine using RFA data whether or not our effort, which is the red line, was better or worse than other hospitals in the state. The blue line shows morbidity in non-SCSQC hospitals. This data is a little bit old now. It goes back to when we first started, the first 3 years or so. Our hospital started with a higher risk of infection, or not just infection, but morbidity, and has improved over time, whereas others in the state who aren't part of the collaborative have actually gotten a little bit worse over time. And this is how we fund it. These are rewarding excellence points, and there's also 2% of Medicaid's quality-based payment program that goes into funding the cost of being in the collaborative. And so that's a quickie 5-minute of what the collaborative is for those of you who don't know. And with that, I know we don't have a lot of time, but I'll stop and take any questions and turn it back over to Nan and company, and let me stop sharing.
Thank you so much. If anybody has any questions, we do have a couple of minutes for questions if you'd just like to put them in the chat. And Dr. Lockett, if someone is interested that's on the webinar today and being a part of the collaborative with their facility, what do they need to do in order to kind of follow up and get some more information about that?
Yeah, we've got Virginia Slocum on, who's sort of our manager, and we can provide contact information for her and myself, and we are happy to set up calls, and we've got some documents that we send out to folks to just show them what it is that we do and some of the results in a little bit more detail than what I presented there. And we just love to have conversations with hospitals. Some hospitals, feel like they have great data. We want them involved in the collaborative too, because our other hospitals who may not be quite as good with some of their data they can learn from those hospitals. So it's not a collaborative of just people who have issues. We all have issues, right? We all have things we're trying to work on. We want everybody in it, because the more people that are in it, the more we can learn from each other.
Great. Well, we will be sure to share, as mentioned earlier, we will be sharing the PowerPoint slides. We will be sure to share both of your contact information. If any of the facilities that are on this call would like more information about participating in the collaborative. I don't see any other questions. So just to kind of recap, I did want to just mention too, we are going to be rolling out a couple of new categories this year, and one will be focusing, award category will be focusing on a drive to zero disparities. So I've really appreciated your mention of that, and some really important data that you showed today, specifically about some disparities that are shown, particularly with surgical site infections. So those are some highlights that we can share with the facilities on the call today, that we will be expanding our priority awards to include the Drive to Zero Suicide, Drive to Zero Disparities, and Drive to Zero Violence, focusing on reducing workplace violence. So you will be hearing some more about that with some of our upcoming webinars and additional award categories. And in May, late May, early June, we'll be hosting another webinar, and we will be reviewing our awards program this year, and talking a little bit more in detail about those new award categories. Again, we will share all this information. If you have any questions after this call, my information is on the screen. Please feel free to reach out to me with any questions. And if you think of something after this, I'll be happy to connect you to Virginia or Dr. Lockett. Any last words, Dr. Lockett or Virginia, before we sign off today?
No, again, just kudos for those that got the zero harm awards, because I mean, again, as I showed you that data, the overall risk of SSI is close to 10% across very common operations. So for those of you who managed to get those awards, and I know some of the facilities I work in have won some of those awards, that's a big deal. So like, we've got those things down in the lobby showing people that we've been able to do that. And so just kudos and thanks. The program's an awesome program, and for those of you who are able to do that, that says tons about your hospital systems and your providers. So good job. Yes,
congratulations to all those hospitals that we mentioned earlier. And we hope that, and we know this was beneficial. That was great information today. So thank you, Dr. Lockett, for your time. And thanks to everyone for joining us today.